I want to move as we're getting close to the end here. I just want to sort of rapid fire here. The two trials with Daratumumab have been in elderly, non-transplant eligible patients. How is this going to impact your use of that drug in a younger population, or do you have to wait for RVD Dara trials?
Honestly, I don't know what we're waiting for, but I'm still waiting. So I'm using KRD as frontline.
It's not covered by insurance right now.
Yeah, but I'm not sure we couldn't, be passed through, or people could play around the system. But I think we'll have the results of the clinical trials pretty soon. And it's important to know as well too that we know that there's myelosuppression with Daratumumab. We see that in combination with IMiDs. I don't think is the case, but we just need to make sure the whole process of stem cell collection and everything is correct as well.
And there's not infectious deaths that overcome worse than the myeloma.
Well, we have first evidence which will be presented at this meeting in transplant setting from Cassiopeia trial, which is using a triplet, but
that was velcade-thalidomide
dexamethasone with or without Daratumumab, and also in transplant patients. So this is first evidence that Daratumumab is improving outcome of these patients, depth of response, and some other parameters. So I think that the writings are already on the wall. We will be using antibody with triplets.
Have you started using it? Or, I mean, if I'm a payer, I'm going to wait for those trials before I pay for it.
Outside of clinical trial, I would not be able to do it. I would not get approval. But we are in fortunate position that we have almost every patient segment able to enroll into a quadruplet with antibody.
And you hearing from patients or your other community providers you interact with about where they think Daratumumab is going to be in younger patients?
People are very interested in Dara, and in the monoclonal antibody therapies in general. So I think that people are looking forward to that. They know that it's coming, and they're looking forward to having access to that in the front line.
Okay. Well, I think what we heard then is that both for younger and older patients, triplets are sort of the current standard. We're hearing a lot of enthusiasm for using Daratumumab to actually replace one of the drugs or perhaps add. But we do feel there's a little bit of a requirement for some more trials to make sure the safety signal is reasonable. I think we also heard from all of you that MRD negative status is optimal, and it may one day give us a reason to not have to treat for years on end if these drugs are as effective as we think they would be.